A heart attack without chest pain sounds impossible, right? But what if I told you that some of the most dangerous heart attacks happen silently, with little or no warning signs, and often go completely unnoticed? Welcome back to our channel. In today's session, we are decoding the concept of silent heart attacks through a real clinical case and an evidence based approach. This is especially important for the MBBS students, NEET PG aspirants, and USMLE prep because these are the cases that are easy to miss but critical to diagnose. By the end of this video, you will exactly know how to identify them, why they happen, and how to manage them effectively. Let's get started. Let us look at this case. A 58-year-old male, Ramesh Patel, a known case of type 2 diabetes for past 10 years. He comes in with something that sounds fairly non-specific: fatigue and jaw discomfort for 2 days. No severe chest pain, no radiation to the left arm. At first glance, this might not raise alarms, right? But now, look at his vitals. Blood pressure is elevated, heart rate just 52 beats per minute. That's bradycardia. And here's the red flag: a diabetic patient with atypical symptoms and abnormal vitals. This is exactly the kind of presentation where silent myocardial infarction can hide in pain silently. So, the question is, are we looking at something benign, or we are missing a life-threatening diagnosis? Let's investigate further. Now, here's the key insight. Why do some patients, especially diabetics, not feel pain during a heart attack? Let's compare this. In a normal pathway, ischemia in the heart generates pain signals. These travel via visceral afferent nerve fibers and reach the brain, so the patient feels classic chest pain. But in diabetes, things change. Chronic hyperglycemia leads to autonomic neuropathy, damaging these same nerve fibers. So, what happens? The heart is still ischemic. Damage is still occurring, but the pain signals never reach the brain. No signal, no perception, no chest pain. That's why these are called the silent heart attacks. And this is exactly why diabetic patients can present with atypical symptoms or no symptoms at all, which makes diagnosis more challenging and dangerous. So, if not pain, what should we look for instead? This is where everything becomes clear. Let's look at the ECG. There's a new left bundle branch block pattern, and that alone should raise immediate concern. And to that, ST depression in leads V4 to V6. This is not normal. This is ischemia starting at U on paper. Now move to the cardiac biomarkers. Troponin I is 2.8 ng per ml. That's massively elevated. So, even without chest pain, even without classic symptoms, the diagnosis is clear: non-STEMI, non-ST elevation, myocardial infarction. This is the danger of silent heart attacks. They don't announce themselves, but the damage is very real. And once you recognize it, you need to act fast. So, what's the next step in management? Alright, now it's your turn to think like a clinician. You have diagnosed an NSTEMI. Vitals show BP is elevated, but heart rate is 52 beats per minute. That's bradycardia. So, what is your initial pharmacological move? Option A: atenolol, a beta blocker. Option B: morphine for pain relief. Option C: aspirin, an antiplatelet. Take a moment, think carefully. This is a classic exam and a clinical trap. Pause the video and drop your answer in the comments, because the right choice here depends not just on the diagnosis but on understanding the patient's physiology and priorities. Ready? Let's break it down in the next slide. Let's start with a common misconception. For years, morphine was considered a go to drug in cardiac patients. But here's the reality: in NSTEMI, morphine can actually be harmful. Why? Morphine causes venodilation, which reduces the coronary perfusion pressure. Less blood flow to an already ischemic heart means worsening of the ischemic injury. On top of that, it can cause respiratory depression and even mask ongoing symptoms. And the evidence studies have shown an increased mortality risk in the NSTEMI patients receiving morphine. That's why it has been removed from the primary protocols in this setting. So, this is not just a wrong choice, it is a dangerous one. Now, let's move to better options and find the correct answer. For years, we were taught one simple rule: MONA, morphine, oxygen, nitrates, and aspirin. Give it to every ACS patient, no questions asked. But medicine has evolved. Welcome to the new era. Based on the latest ACC/AHA guidelines, morphine is no longer routine. Avoid an NSTEMI unless absolutely necessary. Oxygen only if the saturation is below 90%, not for everyone. Nitrates use carefully and always monitor the blood pressure. And aspirin, this remains the undisputed first line life saving drug. So, MONA is no longer a blanket approach, it's now selective evidence based therapy. And here's your exam alert: MONA is still commonly used as a trap in the MCQs. If you follow old habits, you will pick the wrong answer. If you follow concepts, you will get it right. So now, which option stands out as the correct choice? The correct answer is aspirin 325 mg chewed immediately. This is your first line life saving intervention in suspected myocardial infarction. And here's the another key point, that aspirin has no effect on heart rate. But you will think why it is chewed, because it allows rapid absorption through the buccal mucosa directly into the systemic circulation, bypassing the first pass metabolism. That means faster onset of action within the 30 minutes. So, in this patient with baseline bradycardia, it is completely safe. It won't make things worse. While other drugs, depending on the situation, aspirin is your anchor, always indicated unless contraindicated. This is one decision that can truly save myocardium and save lives. Now let's complete the management plan. Now let's quickly understand how aspirin actually works. It targets the COX-1 enzyme, a key step in the pathway that produces thromboxane A2, which is responsible for the platelet aggregation. Aspirin irreversibly inhibits the COX-1, basically shutting down the pathway. No thromboxane A2 means no platelet aggregation and reduced clot formation. But here's the real kicker: platelets don't have a nucleus. So, once the COX-1 is blocked, they cannot synthesize new enzymes. That means the effect of the aspirin lasts for the entire lifespan of the platelet, about 7 to 10 days. So, with one dose, you are creating a long lasting antiplatelet effect. And that's exactly why aspirin is so powerful in acute coronary syndromes, ACS. Let's understand why we give 325 mg initially, the dose of aspirin. The loading dose 325 mg is all about speed. It rapidly saturates the platelets and gives you near immediate maximal inhibition. In an acute coronary syndrome, the timing is critical. You want platelet aggregation blocked as fast as possible. Now, after that, we move to a maintenance dose 75 to 150 mg daily. Why lower? Because now you are not trying to block the existing platelets, that's already done. You just need to maintain the effect by inhibiting the small number of new platelets produced each day. So, think of like this: loading dose, a rapid attack; maintenance dose, sustained control. And that's the science behind aspirin dosing in ACS. Now, let's talk about option A, atenolol, and why it is a serious mistake in this case. Look at the patient's baseline. Heart attack is already 52 beats per minute. That's bradycardia. Now, what does atenolol do? It is a beta blocker. It slows the heart rate even further. This is the negative chronotropic effect and delays the AV conduction, that is negative dromotropic effect. So, if you give atenolol here, you are pushing an already slow heart rate even slower. And the consequences, severe AV block, cardiogenic shock, and even asystole. This is not just inappropriate, it can be life-threatening. So, here's a clinical rule to remember. Avoid beta blockers in ACS if the heart rate is less than 60 beats per minute. This is a classic exam trap. And now you know exactly how to avoid it. So in this case, atenolol is not just wrong, it is dangerous. Now let's put everything together. The complete NSTEMI management arsenal. First, dual antiplatelet therapy. Aspirin 325 mg chewed immediately plus clopidogrel loading dose 300 to 600 mg. This combination is essential to stop the platelet aggregation and clot progression. Next, high intensity statin therapy, atorvastatin 80 mg, not just for cholesterol but for plaque stabilization and anti-inflammatory effects. Then anticoagulation. Heparin, typically unfractioned to prevent further thrombus formation. And finally oxygen, but only if needed. Give oxygen only if SpO2 is below 90%, not routinely. So remember this flow. Antiplatelets, then statins, then anticoagulation and the selective oxygen. This is how you manage NSTEMI in modern evidence-based medicine. And this is exactly what turns a diagnosis into a life-saving intervention. Let's see how this is actually tested in exam. A 58-year-old diabetic with a jaw discomfort, ECG showing ST depression, and most importantly, heart rate of 52 beats per minute. And the question is, which drug is contraindicated? Now many students rush and pick randomly, but the key is to spot the clue. That one number, heart rate 52, changes everything. So the correct answer is atenolol, because giving a beta blocker in a patient with baseline bradycardia can precipitate AV block or worse. While the other options, aspirin, clopidogrel, atorvastatin, are all standard life-saving therapies in non-STEMI. So here's your testing tip. Always check heart rate and blood pressure before choosing beta blockers or nitrates in acute coronary syndrome questions. That one step can turn a tricky question into an easy score. And that's you think like a topper. Let's lock this with a high yield framework. So the presentation in diabetes and elderly myocardial infarction can be painless or atypical due to autonomic neuropathy. The first move, aspirin 325 mg chewed immediately, rapid irreversible antiplatelet action. The trap, avoid morphine in NSTEMI, it can worsen the outcomes. And remember, MONA is outdated. Contraindications, no beta blockers if the heart rate is below 60 beats per minute, or if there are any conduction blocks. If you remember this structure, you will handle both MCQs and real patients with confidence. Thank you for watching. If this helped you, don't forget to like, share and subscribe our channel. See you in the next video.